Hi, this is Jess Davis. Today I'll be talking about Pierre sequence. Pierre sequence has been estimated to occur in approximately 1 out of every 10,000 births. It can occur in isolation or along with other genetic anomalies. While a syndrome is relatively rare, it carries with it serious speech, language, and swallowing difficulties. In nearly all cases, children require medical or surgical intervention. However, the speech-language pathologist plays an important role in the overall craniofacial team. Today I'll discuss several aspects of Pierre sequence, including the main craniofacial syndromes, causes of the sequence, and effects on speech, language, and swallowing, as well as some of the approaches to treatment. So the main symptoms that are seen in Pierre sequence include a very high arched palate or a U-shaped cleft in the palate. These children may have a very small jaw and chin, and a jaw that is very far back in the oral cavity. Children with Pierre syndrome may have palatal fistulas. They may have a large tongue, and it's very common to see ear infections in these children. The exact cause of Pierre sequence is unknown. However, some theories suggest that the mandible becomes stuck during fetal development. The name of this syndrome is referred to as Pierre sequence because of the domino-like series of effects. So it begins in the fetus with that underdeveloped mandible. Like I said, some theories suggest that it kind of gets stuck and it doesn't grow anymore. That small jaw forces the tongue to be carried a little bit higher in the oral cavity, and that results in glossoptosis, or very highly carried and far back carried tongue. And then as a result of that highly carried tongue can result in the U-shaped cleft or the high palate. Pierre sequence may also result from other genetic disorders, such as Stickler syndrome, velocardiofacial syndrome, fetal alcohol syndrome, and Treacher-Collins syndrome. So below I have some of the effects listed, the effects on speech, language, and swallowing. So first, respiration. Glossoptosis, the high and back carried tongue, can sometimes result in the blockage of the nasal and oral pharynx. So as a result of that, the child may have oxygen desaturation, apnea, they're not able to breathe, or cyanosis, kind of turning blue in the face. Effects on resonance, those effects are mainly due to the clefting. Most commonly you'll see hypernasality, as you would in a cleft palate patient, and only about 52% of children with Pierre sequence have a competent velopharyngeal mechanism. As far as articulation, I just wrote here that the child must have adequate structures before they'll be able to adequately produce the sounds. And I wrote that the child may learn compensatory behaviors as a result of not being able to produce those sounds in the first place. Next, swallowing. Dysphagia often occurs in these children secondary to their inability to breathe during feeding. Like I said, there's that blockage of the oral and nasal pharynx, and that creates problems because they're not able to breathe and swallow at the same time. Some of the effects include gastroesophageal reflux and aspiration. In addition to that, the clefting of the palate might prevent the child from adequately sucking due to not being able to create that oral pressure. The infants with Pierre band sequence are known to have failure to thrive. As far as hearing, often see hearing impairment because of those recurrent ear infections. And finally, language disorders may result from hearing loss, and in general, children with cleft palate and Pierre band syndrome are just expected to have some language delays in general. So I've just got a couple of pictures here to kind of help illustrate some of those characteristics that you see in Pierre band sequence. And so in this child, you can see definitely in that profile picture the underdeveloped mandible. That's kind of affecting the profile of the child's face. Similar here in this picture. You can see that this child's got the oxygen, and that just kind of speaks to the respiratory issues that you see in these children. This kind of illustrates the U-shaped cleft that I was talking about. If you look back there in the mouth, you can see that it's essentially an upside down U. And you can kind of imagine how in the fetus development the tongue could have kind of led to the development of that cleft there. And this just kind of illustrates that glossoptosis, the retraction of the tongue in the oral cavity, and you can kind of see how it's blocking off a little bit of that entrance into the pharynx, and that's what leads to a lot of those respiratory difficulties, which then leads to the dysphagia. So here I just have some general guidelines for treatment of children with Pierre band syndrome or sequence. First, like I said before, the child must have the adequate structures in place before speech therapy will be effective in teaching those sounds. However, before the child receives the surgery, the certain skills can be addressed in therapy, and certainly the speech pathologist can provide education. And then also the speech pathologist is a member of a comprehensive team, and that would include the craniofacial surgeon, the audiologist, ENT, orthodontist, prosthodontist, psychologist, geneticist, social worker, and others. So specific to swallowing, treatment will mimic the treatment of children with cleft palate only without Pierre band syndrome. Of course, intervention decisions will be made on a case-by-case basis, but the ultimate goal, as with all dysphagia treatment, will be adequate nutrition and hydration. Some things that the speech pathologist may recommend include position modifications. So an example of that would be a chin or a jaw assist. Also, the side lying or prone position is recommended as well, just to facilitate breathing. Not just for feeding, but to kind of help that tongue and the airway open up. They may recommend diet modifications As the child gets older, certain diet textures may be recommended to facilitate feeding. Adaptive feeding tools may be recommended. Biofeedback, pacing, or cue-based feeding. Certain maneuvers, prosthetics in some situations, sensory stimulation, and finally tube feeding may be the feeding option for certain children with Pierre band sequence. So specific to language, therapy will be similar to children with a general language delay. The focus for these children will generally be on expanding the child's vocabulary and their phonological inventory. Language therapy can generally be combined with articulation and other therapies in order to be more effective and to have higher carryover for the child. And treatment for articulation, goals of early intervention for these children should include increased consonant inventory, including pressure consonants and airflow. And again, this is going to be similar to the approach that you would use with a child with cleft palate, regardless of the cause of the cleft. One suggestion is the use of whispered vowels, which can help facilitate the elimination of the glottal stop substitution, because you're really relying on the production of the stop in that situation. So here are just some resources that may be helpful for more information on Pierre band syndrome or cleft palate in general. Here I've got some references, and I appreciate your time and hope you learned a little something, and have a good day.